am Bhavisha Rohit.
And I'm Samira Sankhe. We are the intern batch from Vedic Dental College.
We are here to discuss about
Expansion in orthodontics, which also includes some subtopics like introduction, slow expansion, rapid expansion, and other methods of expansion.
Let's start with introduction. Expansion is method of gaining space. Expansion of fluid is first achieved by Emerson C. Angel in 1860. Numerous expansion appliances have been described with varying force level and duration of treatment. Classification. Expansion of dental arches can be classified as orthodontic or dental expansion, orthopedic or skeletal expansion, and passive expansion. They can also be classified broadly as slow expansion and rapid expansion. Armamentariums are screws, loops, springs, flexible wire like nickel titanium. Indication of expansion. Indications are maxillary transverse deficiency, crossbite, mild crowding, expansion along with functional appliance treatment, skeletal class 3 malocclusal, distal molar movement, and surgical orthodontics. Maxillary transverse deficiency or crossbite. Maxillary expansion has become a routine procedure in treating maxillary transverse deficiency in variety of malocclusion in young orthodontic patients. Maxillary expansion is undertaken for the correction of posterior crossbite. Maxillary expansion may help to eliminate mandibular displacement associated with functional crossbite. They are also used to treat bilateral crossbite involving buccal teeth. Then mild crowding. Maxillary arch expansion may be used in certain carefully selected cases for the relief of mild crowding. They are most effective when mild crowding is combined with narrow dental arch. Expansion along with functional appliance treatment. Myofunctional appliances are commonly used in treatment of class 2 malocclusion in growing patients. In majority of those patients, it may be required to expand maxillary arch during treatment in order to maintain arch coordination as the wider area of mandible is advanced in relation to maxillary dentition. The amount of expansion required can be estimated by asking the patient to move his mandible forward and bite an edge to edge position and noticing the size of transverse discrepancy that develops in buccal segments. Example of functional appliances that can produce expansion include twin block appliances with expansion screw, functional regulator appliances of Frankel, and other functional appliances that incorporate buccal shield. Skeletal class 3 malocclusion. Maxillary protraction using reverse pull headgear or face mask can be used for management of skeletal class 3 malocclusion in growing patients. Rapid maxillary expansion along with the reverse pull headgear helps to loosen maxillary sutural attachments so as to facilitate protraction. Distal molar movement. Headgear is often used to distalize the maxillary molars to increase arch length or relief of crowding and avulsion reduction. During distal molar movement, it is important that the intermolar distance is increased so that crossbite is not created in the molar region as a narrower part of upper arch is moved back against the wider part of lower arch. Expansion is in these cases can be achieved by slightly expanding the inner bow of headgear by using removable appliances with midline expansion screw in conjunction with headgear. Types of expansion: orthodontic or dental expansion. This type of expansion produced by various removable expansion plates and conventional fixed appliances. The resultant expansion is dentoalveolar in nature, producing primarily lateral tipping of crown and lingual tipping of root. Orthopedic or skeletal expansion. In this type of expansion, the changes produced are skeletal in nature rather than tipping of teeth buccally. Example of skeletal expansion is rapid maxillary expansion. This type of expansion results in separation of mid-palatal suture and also has an effect on circumzygomatic and circummaxillary sutures. Passive expansion. Passive expansion is produced by shielding of buccal and labial muscles with the resultant expansion of arches. Thus, this type of expansion is not produced by extrinsic forces but rather is result of intrinsic forces such as produced by tongue. An example of this type of expansion occurs by use of FR2 appliance and lip bumper. Let's start with slow expansion. Slow expansion has traditionally been termed as dentoalveolar expansion, although some skeletal changes can be observed. The slower expansion have also been associated with more physiologic adjustment to the maxillary expansion, producing greater stability and less relapse potential than in rapid maxillary procedures. The forces generated by such procedures are 2 to 4 pounds, expanded slowly at rate of 0.5 to 1 mm per week. Pure dentoalveolar expansion should be always slow. Diagnostic aids for slow expansion. Diagnostic aids such as case history, clinical examination, study model, maxillary occlusal view radiograph to see mid-palatal suture and PA cephalogram to estimate amount of expansion. Appliances used for slow expansions are fixed W arch, quad helix, and night-eye arch wires. Removable appliances are coffin spring and expansion screws. Functional appliances are twin block appliance with incorporated screw and functional regulator appliance. W arch wire. 0.9 mm stainless steel wire soldered to molar bends. Patient corporation is not required. Preferred in deciduous and mixed dentition where mild to moderate expansion is required. Activation is done by outside mouth 3 mm wider than passive width. Second is quad helix. It was described by Ricketts. It incorporates 4 helix that increase wire length, therefore flexibility and ranges of action of this appliance is more. This appliance is constructed using 0.038 inch wire and soldered to bends on first molar. Activation either inside or outside mouth 4 mm wider than passive width. Retained for 3 to 4 months after outcome is achieved. Third one is night eye expander. It has capacity to rotate, upright, distalize and expand the anterior and posterior arch with gentle biocompatible force. It is capable of uniform slow continuous force. Depends on shape memory and superelasticity of night eye transition temperature is 84 degree Fahrenheit continuous force level between 230 grams to 300 grams. Available in 8 intermolar widths ranges from 26 to 47 mm. Freeze gel packs can be used to make appliance flexible for insertion. Fourth one is coffin spring. It is removable appliance capable of slow dentoalveolar expansion. The appliance consists of omega-shaped wire of 1.25 mm thickness placed in mid-palatal region. Free end of omega wire embedded in acrylic covering slope of plate. Activation. Spring is activated by pulling two sides apart manually. It can also be activated by using 3-prong plier. Fifth one is expansion screw. Expansion screw is very small metallic appliance which may be designed to move single tooth or group of teeth or skeletal bases as required. This screw is source of force together with the acrylic segment of plate effect the teeth and alveolar process. Different type of screw may be used advantageously for certain procedures during treatment with removable appliance.
Comparison of rapid and slow expansion. There are different points which will create a comparison point. First is type of expansion. In slow expansion, there is both skeletal and dental changes from beginning, where it has 60% dental changes and 40% skeletal changes. Now we can see in rapid expansion, predominantly skeletal changes are seen initially, later dental changes are seen with skeletal relapse. So there is also 60% skeletal changes and 40% dental changes. Rate of expansion. Slow expansion of slow rate, rapid expansion of rapid rate. Type of tissue retraction. In slow there is more physiologic type of tissue retraction, whereas in rapid there is more traumatic. Force used in slow is milder force, about 2 to 4 lbs, whereas in rapid expansion the force uses greater force, which is 10 to 20 lbs. Frequency of activation. Slow expansion have less frequent. Rapid expansion is more frequent. Duration of treatment. Slow expansion takes more or long period of time, whereas rapid expansion takes shorter period of time. Type of appliance, either fixed or removable. Slow expansion. In rapid expansion, mostly fixed appliances. Age. Slow expansion, it can occur at any age. Rapid expansion before the fusion of mid-palatal suture. Retention. In slow expansion, lesser chance of relapse is seen. In rapid, there is more chances of relapse. Amount of expansion achieved in slow is 0.5 to 1 mm per week, whereas in rapid 0.5 to 1 mm per day. 10 mm of expansion is achieved mostly, approximately, in rapid expansions.
Thank you. Here I completed my topic. Further rapid will be continued in another video.